Hi there, my name is Julie Donnelly, and today this presentation will be on the preterm infant and inverted nipples. So what we will discuss today, we will discuss how a mother with inverted nipples will breastfeed her preterm infant, and we'll use it following the situated clinical decision-making framework, and we'll outline 3 best practice measures used to resolve breastfeeding with inverted nipples in a preterm infant using the 3 rules. So feed the baby, move the milk, and help the mother-infant dyad to breastfeed. So using the situated clinical decision-making framework, we have 5 components: knowledge, cues, judgment, decisions, and evaluation. So knowledge is our understanding of the health challenge and pathophysiology involved. Cues is our signs and symptoms of that health challenge. Judgment is what we use within our thought processes to best identify what is happening with the mother-infant dyad. Decisions are to determine what types of consultations we would refer the dyad to. And evaluation of both the outcome of the mother-infant dyad and ourselves in our nursing care. So knowledge, the preterm infant. So a preterm infant is a baby born less than 37 weeks gestation. It can be resultant of a weakened cervix that dilates too early, infection, poor nutrition right before or during pregnancy. And as you know, these infants are usually more susceptible to feeding difficulties because of their abnormal breathing patterns, so shallow, irregular pauses in breathing, otherwise known as apnea. They have lower muscle tone and are less active than full-term infants. So they have a little bit of a failure to thrive at times. They have trouble sucking or coordinating swallowing and breathing. So as you know, this can be really difficult during breastfeeding if they're trying to pace themselves and try to suck, learn to suck. And difficulties regulating their body temperatures. So they have less body fat than full-term infants. And when they do feed, they may use up more energy stores quite quickly, so they're more susceptible to having hypoglycemia and being generally feeling unwell and probably less likely to want to feed. So knowledge and inverted nipples. So inverted nipples can occur when lactiferous ducts do not get properly stretched during puberty. They have a dimpled appearance folding into the areola, and there are 3 different grades. So grade 1, these nipples can occasionally become everted from arousal, temperature changes, and stimulation. They can also protrude through manipulation by lightly squeezing fingers around the areola a few centimeters behind the nipple. So they will protrude and they will maintain protrusion without retracting. So breastfeeding is definitely possible with grade 1 inverted nipples. Grade 2 inverted nipples. These ones are not as easily manipulated out. They don't hold their protrusion after the pinching is released. So breastfeeding is a little more difficult with grade 2 nipples, but it is definitely possible. And then grade 3, these nipples are severely retracted into the areola, meaning they cannot be pulled through physical manipulation. And the milk ducts tend to be constricted, so breastfeeding is almost rendered impossible with grade 3 inverted nipples. So this is an illustration of grades of inverted nipples on the bottom right from left to right, grade 1, 2, and 3. So as you can see, grade 3 is very inverted, and we can determine that as opposed to grade 1, which can be protruded quite easily with the use of pinching on the back of the areola to protrude, and grade 2, just slight coaxing, a little more of a difficult time to try and get it out, but definitely possible to breastfeed with grade 1 and 2. So cues, what should we be looking for in terms of the preterm infant and signs of ineffective breastfeeding? So a baby's not going to be latching or sucking properly. There's going to be decreased weight gain or weight loss. Baby's going to be quite lethargic in general and or at the breast. And there's going to be irritability, so baby may show signs of increased fussiness approximately 1 hour or even less after breastfeeding and may be inconsolable. So this just shows that baby is not feeling full and they're not satisfied enough to properly grow and sleep and regulate their patterns. So cues, what should we be looking for in terms of mother and signs of ineffective breastfeeding in terms of inverted nipples? So we want to make sure that we understand the grade of nipple aversion that this mother has. So is it 1, 2, or 3, and determine the course of treatment or support that we should give her. She's probably going to have sore, cracked, or bleeding nipples, a decreased milk supply, and definitely increased frustration. So judgment. So to take a look at all the information we've collected to determine a course of treatment that we want to have for that mother, it's going to be tailored to that mother and that infant dyad, of course, because everyone's different. So we want to apply the 3 important points of feed the infant, move the milk, and help the mother-infant dyad learn to breastfeed. So feed the infant. So we want to establish a routine of feeding the baby every 1 to 3 hours in the first few weeks after birth. Feed 8 or more times in 24 hours. Ensure the baby has a proper latch. So if issues continue to arise from the averted nipples in this case, we want to have mom use nipple shields, maybe nipple stimulation with a cold compress, and gavage feeds may be needed for preterm infants. So what we want to do is we want to have skin to skin and have baby exposed to breast as much as possible, maybe suckling or licking at the breast, so that they associate a breast with a full tummy. Okay, so the second is move the milk. So after birth, we want to try and get mom to express some colostrum and become accustomed to hand expression. So for mom with inverted nipples, she can stimulate the nipple by grasping it and rolling it in between her fingers or use a cold cloth. Pulling back on the areola before latching the baby, this will help protrude the nipple. And use a nipple shield if she can, or if it's appropriate. This can facilitate obtaining a latch and maintaining milk production. As well, we want to encourage skin to skin and do breast compressions while breastfeeding as much as possible. So, help the mother-infant dyad learn to breastfeed. This is our third and final rule. So we want to work on techniques of latch and position, whatever works for her and her baby. We want to encourage skin to skin, and we want to support the mother and encourage and motivate her to breastfeed. A lot of mothers can feel as though it's almost like a chore, and we want to ensure that it's a positive experience for her and her baby. So, decisions. So we want to determine what else can be done for the mother and her baby. So lactation consultant referrals, is there further consultation that needs to be done about the use of nipple shields if she's using them or if it's an appropriate treatment for her? Positions like football hold, sideline, and herbal remedies. We want to support her in her breastfeeding experience as well, and we want to assess the need for outside support networks. So is she a single mom? Will she need outside support post-discharge? So we want to determine that depending on the different situations that we were presented with. So evaluation, our final part of our situated clinical decision-making framework. So babies' weight gain, ins and outs, numbers of wet and stool diapers throughout the day. Is the baby latching, sucking, and swallowing properly? Is mom comfortable and confident about her breastfeeding experience? Does she know what to look for in terms of feeding cues, engorgement, signs of a full baby? Does she feel supported enough? And how are her nipples? We want to determine if she's having any issues with protrusion or keeping baby latched. And as well, we want to have mom teach some of the things back to us just so that we can evaluate her properly to determine if she understood the teaching. So finally, our conclusions. So we want to follow the 3 basic rules of feed the infant, move the milk, and helping the mother-infant dyad learn to breastfeed. So I want to explain that it is possible to breastfeed a preterm infant. Hand expression can definitely go a long way for a mom and her baby in their breastfeeding experience and their future. And it is possible to breastfeed an infant with inverted nipples. All it requires is support, teaching, and practice. And I want to emphasize that as nurses, we have to remember that not all cases are the same. We should learn to tailor each plan and teaching to each mother-infant dyad according to their current situation. Everyone's different.